Thank you so much. It's such a pleasure to have you all here today. I hope you enjoyed that little bit of flashback Madonna in the waiting room music as you were waiting for this course to begin. We're super excited about this program today. It's going to be fantastic. We have an all-star lineup of speakers. And frankly, I think that this is a wave of the future, that we're going to be talking about ways to prevent and to control cancer, detect them early. We have several hundred, over 700 healthcare providers registered here today from over 70 countries. And so we welcome you wherever you are in the world. We're so happy to have you with us today, and feel free to really interact with us and to ask plenty of questions so that we can ensure that you're getting the most that you can from the program tonight. Next slide. As always, we're incredibly pleased to have the support and sponsorship of our important partners. This includes Cook Medical, Johnson & Johnson, and Medtronic. So thank you so very much for your support of our continuing educational programming. We're very grateful, and we know that these types of programs could not proceed without your support. Thank you. And so with that, I'm very pleased to briefly just say hello, and I will be also introducing my co-moderator and co-director and partner in crime, Dr. Mohuddin. And just wanted to, again, let you know how very excited we are to have all of you, and we're excited to interact with you. I see a lot of languages and a lot of people telling us about the countries that they're joining us from: South America, from the Middle East, are just a few of what I've seen so far. And so we're thrilled to have you. And so with that, I'll hand it over to Dr. Mohuddin. Syed, would you like to welcome our participants and say a few words about our speakers?
Of course, yes. Thank you, Dr. Kim. And I welcome everybody to today's session. It's a privilege to host this. And of course, everybody is here, and we are all talking about prevention and screening, which is perhaps the most important factor in today's day and age in our fight against cancer. And who better to talk to us about prevention and screening of GI cancer than the amazing list of faculty we have today. Dr. Prashanthi Toda is going to talk about esophageal cancer. Dr. Carol Raphael is going to talk to us about stomach cancer. Dr. Ari Garber is going to talk to us about colon cancer. Dr. Tyler Stevens is going to talk to us about pancreas cancer. And lastly, Dr. Shilpa Juna is going to talk to us about liver cancer. So that's an amazing lineup, folks. So thank you all for being here. And without much ado, I would like to introduce Dr. Prashanthi Toda. She's the director of Esophageal Center at the Cleveland Clinic. And she's going to talk to us and enlighten us about prevention and screening of esophageal cancer. Prashanthi, I'm just going to tell the audience that each presentation would be about 10 to 12 minutes, and we'll serve about 3 to 5 minutes of questions. So if anybody has questions, they can put that up in the chat box. Why don't you enlighten us a little bit about esophageal cancer and coffee, perhaps, or our presentation's there. Okay,
there it is. Yeah.
Okay, let's go.
So good evening, everyone, and good morning and good afternoon. And I thank Dr. Michelle Kim and Dr. Syed Mohuddin for inviting me to speak today about esophageal cancer. So we'll address your question, Syed, in a short while, in a couple of minutes. So why do we care about esophageal cancer? So esophageal cancer accounts for probably about 1% of the cancers in the United States, but it accounts for 2.6% of the cancer-related mortality. The 5-year survival is still very low. It is about 22%. The only cancer with the worst 5-year survival rate is the pancreatic cancer. So the projected numbers for the 2026 in US, it accounts for the new cancer cases, approximately 22,530. And then expected number of deaths from esophageal cancer is about 16,290. So the numbers slowly continue to increase. And there is a lot of disparities in terms of the incidence of the esophageal cancer and mortality related to the cancer, and it predominantly affects the males. And as you see the numbers there, both the cancer incidence and then the cancer prevalence, the male to female ratio is about 3 to 4:1. The two predominant kinds of predominant histological types of esophageal cancer are esophageal adenocarcinoma and the squamous cell cancer. Worldwide, squamous cell cancer is the most common cancer, and then cases from China contribute about 25% of the esophageal cancers. In the US and then the Western Europe and Australia, the predominant cancer is the esophageal adenocarcinoma, and it accounts for approximately 70% of the cancers, whereas the squamous cell cancer accounts probably for about 30% of the esophageal cancers or so. Next slide. So coming to the risk factors of the esophageal cancer, and then here are all the numbers I got from all the various studies or so, and then this would be useful to know. So the male to female sex ratio is about 4:8, and then it is common in older populations, so there is 5 to 10 times the increased risk compared to patients younger than 50 years. And then there seems to be a dose-dependent relationship between GERD symptoms and then the esophageal cancer. Patients with weekly GERD symptoms about 5 times increased risk for esophageal cancer than those without, and patients with daily GERD symptoms approximately 7.4 times increased risk for esophageal cancer. Obesity, that is a BMI more than 30, or rather the visceral adiposity, is associated with increased risk of esophageal cancer. Among all the risk factors, the Barrett's is the one which is with the highest risk factor for esophageal adenocarcinoma. Patients with Barrett's esophagus are 30 to 60 times increased risk of esophageal cancer. And then previously, the family history of Barrett's or esophageal adenocarcinoma has been thought to be about 12 times increased risk as those without a family history, but most recent studies with a wider population seem to show that there is just a modest increased risk with a family history of Barrett's or esophageal adenocarcinoma. In contrast with squamous cell cancer, the alcohol consumption is associated with just a modest increased risk for esophageal adenocarcinoma. Next slide, Steve. So the screening for esophageal cancer is not indicated in general population, as opposed to, like, say, the colon cancer screening or so. So almost all the societies, the ESG, there's the European Society, the ACG, ASG, and BSG, the British Society of Gastroenterology, they all recommend screening patients with GERD with one or more risk factors. So, but over the years and with the increased recognition, up to 40% of patients with Barrett's esophagus do not have any prior GERD symptoms. So if we are using only GERD, we are eliminating that 40% of the patients with Barrett's esophagus without any prior GERD symptoms. So AGA has come up with the new guidelines recently. Now, GERD is not necessary. It's an absolute risk factor for screening of esophageal cancer. Any of those 3 established risk factors for Barrett's or esophageal cancer: male sex, non-Hispanic white, age more than 50 years, a smoking history, GERD symptoms, a positive family history or obesity, presence of 3 or more of the symptoms are enough to consider screening for Barrett's esophagus or esophageal adenocarcinoma. Next slide. So the main method for screening for esophageal cancer is a standard upper endoscopy. The eyes do not see what the mind does not know. Now look at it on the left-hand side of the screen. That is looking at the esophagus under white light. And then if you're doing a cursory exam, you'll completely miss that island of Barrett's mucosa, which you see in the narrowband imaging on the right-hand side image. So you have to spend time when you're doing the examination of the esophagus or the stomach. The standard recommended is 7 minutes for an upper endoscopy. Next slide. Next slide, Steve. So here is another example, and this is a patient I have seen. And when you're looking at it, what do you see? You see a small tongue of Barrett's esophagus, or the salmon-colored mucosa, approximately between 12 and 1 o'clock. And then you see a small hiatal hernia. And what else do you see? If you focus on that 1 o'clock position, you see something there. Next slide. So this is under narrowband imaging and then with partial deflation. So when you see this, so now you're seeing that lesion with a central depressed surface. Next slide. And this is a close-up view of that lesion. Next slide. So I did an EMR of this lesion, and then the EMR showed an intramucosal cancer. Next slide. So that's the reason a careful examination is important when you're doing an upper endoscopy, using partial deflation, and then spending time using narrowband imaging, doing deep retroflexion, trying to get into the hernial sac and looking for any lesions. Those are crucial for looking for any early esophageal cancers or so. Now, the endoscopy is expensive. So it requires sedation, it requires a driver. The procedure itself is associated with certain expense, direct cost. So, and it requires the use of a gastroenterologist or an endoscopist and a dedicated endoscopy unit. So are there any cheaper ways of screening for Barrett's esophagus or esophageal adenocarcinoma? Now, the two which are available, non-endoscopic screening methods, on the left-hand side is the EsoCheck. And then on the right-hand side is the cytosponge. EsoCheck is available here in US right now. And then what it entails is, it is actually so this balloon, it has a surface texturing, and then it is deflated. When it is deflated, it is hidden inside this capsule, and it is attached to a string. So the patient swallows the capsule with a string, and then you can, once it enters the stomach, you can inflate it with the use of a syringe. They inflate the balloon and then drag it along the lower esophagus, and then collect the cells and then deflate the balloon and bring it out. Usually, typically, this test takes about 2 to 5 minutes. And then it is not looking for actual Barrett cells. What it looks for is the DNA markers associated with the Barrett cells. And that is the vimentin and the cyclin A. Whereas the cytosponge, which is available in UK, and so this is what it looks like. So it is within, the sponge is within a capsule, and then it has a gelatin coating, and it is attached to a string. So the patient swallows the capsule and the string is outside in the mouth. And then once it goes into the stomach, the gelatin capsule dissolves. Usually it stays in there for about 5 minutes, and then you drag it up, and then you look for the DNA markers, the trefoil factor 3 within this. So there is extensive studies in UK, Dr. Rebecca Fitzgerald has done, and then and it is being used for screening in several UK clinics. Now, EsoCheck is currently available with Lucid Diagnostics, and then currently a study is underway to look for Barrett's esophagus in patients without any prior GERD history or GERD symptoms. Next slide. Going on to the esophageal squamous cell cancer. So we'll get to that question once we are done with the presentation, Arjun. So going on to the esophageal squamous cell cancer, there are no society recommendations or guidelines per se. And I have these two slides here about the risk factors associated with esophageal squamous cell cancer, and then the expert recommendations about what needs to be done. As we know, esophageal squamous cell cancer, the two most common risk factors are smoking, alcohol use, high prevalence in East Asia, and then Southeast Asia, and then East and South Africa. And then also the hot beverage consumption along the Iran belt, that is one. And then patients with prior history of head and neck squamous cell cancer or at increased risk for esophageal squamous cell cancer too. So the recommendation is to do a surveillance endoscopy afterwards at every once a year or so. Then patients with atrophic gastritis or achlorhydria are also at increased risk for esophageal squamous cell cancer. Next slide, Steve. So here are some of the conditions, pre-existing conditions associated with increased risk of esophageal cancer. And then one of those with the highest risk is the tylosis. So endoscopy is recommended at age 30 or every 1 to 3 years after making the diagnosis, whichever comes earlier. And also in patients with prior caustic ingestion is endoscopy is recommended after 15 to 20 years, surveillance endoscopies. And in patients with at increased risk for other esophageal squamous cell cancers or patients with a prior history, lichen planus, epidermoid metaplasia, as well as the Plummer-Vinson syndrome. In terms of the achalasia, we do know that with long-standing achalasia, there is increased risk of squamous cell cancer, but there are no formal guidelines. What is suggested is doing an endoscopy every 5 years after 10 to 15 years of disease. Next slide. So in terms of the chemoprevention per se, there have been several agents which have been studied, but none recommended because the results are not replicated in other studies or because of the associated other risks associated with taking these medications. Next slide. So in terms of prevention, what is recommended is the risk factor modification. And then, avoidance of smoking, alcohol use, and then treatment of GERD in patients with in high-risk patients to reduce the risk of esophageal adenocarcinoma. Second one is screening. High-risk population, and then currently the preferred modality of screening is a high-quality upper endoscopy. And then in patients with Barrett's esophagus, PPIs are recommended as chemoprevention for esophageal adenocarcinoma. And then in either squamous dysplasia or with Barrett's esophagus with dysplasia, endoscopic therapy, endoscopic ablative therapy is recommended. Thank you.
Perfect. Thank you. Thank you, Prashanti. Thank you so much for that presentation. It was truly enlightening. I have a couple of questions, and I see a couple of questions there in the chat box too. Firstly, what I would want to know is how accurate is this cytosponge? Because I think this is the new kid on the block. How accurate is this for detection of Barrett's as opposed to adenocarcinoma?
So it is mainly for detection of the Barrett's per se,
Okay.
not necessarily for the esophageal adenocarcinoma. So cytosponge has been studied really well in UK, and then its sensitivity seems to be over 90% or so. And then the cytosponge was released in the US market. It was available for research purposes in the US markets, but there were some cases of detachment from the string. So that is why it is currently not available in US. EsoCheck, we have studied that. We are one of the centers who looked at that. The sensitivity appears to be about 92 to 93% or so.
Perfect. And do you think this is perhaps a potential modality for screening in the future?
Absolutely, because this is much cheaper.
Okay.
And then it can be done in the primary care offices.
Okay.
And typically it takes about it takes about approximately 5 minutes or so to do the study. For the patients to swallow, typically it is about 2 to 5 minutes. And then, but the thing is, it is not acceptable to all. So if you look at the EsoCheck, probably about 10% of the patients could not tolerate it, and it is slightly higher with the cytosponge.
Okay. All right, good. Well, one other question, and this is something a little practical, Prashant, Dr. Thoda, which is oftentimes patients with Barrett's would come up and ask, "Hey, can I drink coffee? And if so, how much?" What do you
So
advise?
there is no the coffee consumption having a deleterious effect in terms of the Barrett's esophagus per se. But it is like a weak risk factor for GERD. So if there is any relationship between coffee intake and Barrett's esophagus, it is minimal.
Okay, good.
There's no contraindication for Barrett's per se in terms of the coffee consumption. So it is based on their symptoms. If you're having too much acid reflux symptoms, don't. If not, like 1 to 2 cups doesn't harm.
Okay,
If anything, there seems to be a protective effect for prostate cancer.
sure.
So there is a question asking about how much time to be spent while doing an endoscopy. The studies and then the recommendation from East Asia societies is about 7 minutes for an upper endoscopy. And if there is Barrett's esophagus, the recommendation is to spend like 1 minute per 1 centimeter of Barrett's esophagus.
All right, perfect. Thank you so much, Dr. Thoda. That was truly enlightening.
You're welcome. Thank you for inviting me.
Thank you. Thank you very much. All right, now, without much ado, let's move on to our next presenter, Dr. Carol Raphael. Dr. Raphael has a huge interest and leads major research at Cleveland Clinic for gastric intestinal metaplasia, and who better to talk to us about this than Dr. Raphael. Carol, you're up.
Thank you, Dr. Mohideen, for the introduction, and thank you to the organizers for inviting me to speak today. I'm going to go ahead and share my slides. Okay. Let me know if you are able to see them.
You can.
Wonderful. Good evening, everybody. So for the next 10 minutes or so, I'm going to be talking to you about the prevention and screening for stomach cancer. I'm going to start with an overview of the epidemiology of gastric cancer and then review the current state of gastric cancer screening in the United States. And for reference, throughout this talk, gastric cancer will refer to non-cardia adenocarcinoma. And then finally, I will end my part of the talk discussing gastric cancer prevention through surveillance of gastric preneoplastic lesions. So gastric cancer remains the fifth most common cancer and the fourth leading cause of cancer-related deaths worldwide. There is, however, a marked global variation in gastric cancer incidence and mortality, with higher incidence in East Asia, Eastern Europe, and South America, partly mirroring the prevalence of H. pylori. And you can also see how incidence in blue and mortality in red go hand in hand, unfortunately. The US is an overall low incidence country with an estimated 27,000 new gastric cancer cases and 10,000 gastric cancer related deaths in 2023. The burden of the disease, however, in the US is not homogeneously distributed. And we have certain US non-white immigrant populations at 2 to 13-fold higher risk for gastric cancer compared to non-Hispanic whites. And this is a nice study from the California Cancer Registry data showing that all non-white groups had a significantly higher incidence rate of gastric cancer compared to non-Hispanic whites, which were used as reference in this study. And even among specific groups, such as East Asians, for example, you can see that the incidence rate among Korean was the highest, much higher compared to Japanese in America, for instance. And this is a meta-analysis showing that immigrants from high incidence to low incidence gastric cancer regions maintain their increased risk of gastric cancer. And with that said, the US immigrant population peaked at nearly 16% in January of 2025. And there is a denser immigrant population in metropolitan areas, which really speaks for a potential need for a more personalized approach when it comes to gastric cancer screening that would take into account not only race, ethnicity, environmental and genetic factors, but also country of origin potentially. And in the US, gastric cancer mortality remains high with a 5-year relative survival of 38%. And this indicates that it could be the case because of a diagnosis of the disease at a later stage. And in this table here, you can see a comparison between South Korea and Japan, which are two high incidence countries that have implemented gastric cancer screening programs compared to the US. And more than 50% of gastric cancers in the US are diagnosed at regional and distant stages, as opposed to 50% of those cancers diagnosed at a localized stage in South Korea and Japan. And similarly, all-stage survival exceeds 60% in those countries, as opposed to only 32% in America, which indicates that gastric cancer screening can potentially improve outcomes through earlier detection. So what is the state of gastric cancer screening in the US? And is there a role for screening? It's a question that's difficult to answer because we lack US-specific data. And statements from societal guidelines in the US rely on low quality or evidence or even no evidence at times. So this is a statement from the ASGE in 2014 for the US population, where they state that endoscopic screening for gastric cancer in first-generation US immigrants from high-risk regions may be considered starting at 40, particularly if there is a family history of stomach cancer in a first-degree relative. The ACG guideline published in 2025 suggests against routine screening in the general population in the United States. And note that the two key terms in this statement are routine and general population. They were not able to make a recommendation on opportunistic screening with upper endoscopy, which is the gold standard, in individuals considered high risk based on their immigration status, race, or other risk factors, not because screening is not warranted, but due to insufficient direct evidence from US populations. And this is a statement from the AGA clinical practice guideline or update, where they do acknowledge that there are identifiable high-risk groups in the US who should be considered for screening. And then again, they highlight first-generation immigrants from high-incidence regions, non-white racial and ethnic groups, family history in a first-degree relative, and of course, hereditary cancer syndromes. So what about preventing gastric cancer through surveillance of known gastric preneoplastic lesions? So this is the Korea cascade, which starts with normal mucosa. Gastritis occurs because of an insult, which 80% of the time is secondary to H. pylori infection. And then it will progress through a stepwise cascade to intestinal type adenocarcinoma eventually. The preneoplastic lesions or preneoplastic changes in this cascade include atrophic gastritis, intestinal metaplasia of the complete or incomplete type, and dysplasia. For the sake of this talk and because of the limited time, I'm going to focus on intestinal metaplasia or GIM. So in the United States and probably elsewhere as well, GIM is mostly diagnosed incidentally on random biopsies performed for different indications or symptomatology. And when patients are diagnosed with gastrointestinal metaplasia, the next steps are to risk stratify them. Do they require surveillance? Are they at increased risk of progression? Did they receive a high quality endoscopy? So again, echoing what Dr. Sota mentioned earlier. And if not, do they need to repeat an endoscopy to ensure no lesions were missed and to complete the mapping process for risk stratification purposes, and then offer surveillance when indicated? To risk stratify patients, we need to look at several risk factors. Their H. pylori infection status. We all know that H. pylori is a class 1 carcinogen, and studies have shown that H. pylori eradication decreases the risk of incident gastric cancer. So it should be checked for and treated in patients with preneoplastic lesions. Do they have a family history of stomach cancer in a first-degree relative? And a family history increases their risk significantly. What is the extent of gastric intestinal metaplasia or even atrophy? And to determine this, it is very important to map the stomach according to the Sydney protocol. Limited GIM is limited to the antrum, where the Sydney protocol includes taking biopsies from the lesser and greater curvatures of the antrum and the incisura, and then placing them in a separate bottle, and then biopsies from the lesser and greater curvatures of the body and placing them in another bottle. The Sydney protocol encompasses random biopsies. but it's also important to be targeted to avoid missing those patchy preneoplastic lesions. And to be targeted, it is important we are able to identify the endoscopic characteristics of atrophy and GIM, which I'm covering in this talk, easily. And those include a tubulovillous pattern, which we can more so appreciate typically in the corpus of the stomach, where the pit pattern is typically circular and round, and the tubulovillous pattern may indicate metaplasia. The light blue crest sign, which is easily notable under NBI, was near focus or enhanced endoscopic technologies. And then the white opaque substance, which can be seen as thick white plaques, and this is due to mucosal microscopic lipid droplets in the metaplastic lining. And then there are two histological characteristics that we also look at. And those are rarely employed by pathologists in the United States. One of them is the subtype. Is it complete? Does it have goblet cells? Does it look like small bowel? Or is it incomplete, where goblet cells are lacking? And the incomplete subtype increases the risk, is associated with an increased risk of progression. And then the histological severity. What is the degree or percentage of glandular involvement? And this is typically done via the OLGAM, or operative link on gastrointestinal metaplasia staging system, which requires biopsies per the Sydney protocol. And then based on glandular involvement in the antral biopsies or the corpus biopsies, patients get a stage of severity. And typically stages 2 and beyond are considered higher risk and associated with an increased risk of progression. And then high quality endoscopy. Again, a lot of those elements were mentioned by Dr. Thota earlier. It's very important, especially when screening and surveilling preneoplastic lesions. And that's a nice study showing that 11% of upper GI cancers are missed at endoscopy up to 3 years before diagnosis. And 0.25% of all EGDs have missed existing upper GI cancers. So this is a nice schematic summary from a recent AGA clinical practice update on high quality endoscopy, summarizing best practice elements of endoscopy. So of course, ensuring adequate visualization by washing adequately, aspirating fluids, using defoaming, mucolytic, and proteolytic agents when needed and when available. And that's a nice example showing a normal, what appears to be a normal mucosa here, but upon cleaning further, an underlying cancer has been identified. And that's another example of what appears to be potentially acceptable insufflation, but with more insufflation for better visualization, another lesion is identified in the stomach. A systematic screening protocol of the stomach is also essential, especially in high-risk patients. So ensuring we are systematically visualizing the stomach in a clockwise or counterclockwise fashion, looking at all 4 quadrants of the stomach in an antegrade view, starting in the antrum, back to the lower body, mid-upper body, which is also very important to inspect in a retroflexed view, in addition to the fundus cardia and incisura in a retroflexed view. And ideally, photo documenting those stations as a surrogate for a complete high-quality examination. And then using high-definition white light endoscopy and image enhancement technology, such as narrowband imaging. And that's another study showing that mapping of the stomach under NBI had 100% per patient yield of GIM detection, compared to NBI and white light endoscopy without mapping, or compared to mapping under high-definition white light endoscopy without NBI. And last but not least, which has been mentioned earlier this evening, ensuring sufficient inspection time. And that's an older study showing that the detection rate of high-risk lesions upon EGD increased with increased mean procedure time for an exam. And again, a minimum of 7 minutes has been proposed and is suggested by societal guidelines in the US and internationally to avoid missing lesions. And then last but not least, endoscopic surveillance when indicated. Who requires endoscopic surveillance? This is based on low quality evidence for US populations. So once a risk stratification has been completed based on everything we discussed, race and ethnicity should be considered, but there are no studies to show a direct association with progression. Immigration status should be considered, as we saw earlier. Then the recommendation every 3 years should be given to patients, and even at shorter intervals if multiple risk factors are present. The same applies for atrophic gastritis, which we're not covering in this talk. And then, of course, naturally, the next question that comes to mind is screening and surveillance, are they cost effective? We don't have direct data, but we have simulation models to try and answer these questions. And this is a nice simulation model looking at a 50-year-old person of any race, and then comparing different scenarios to no endoscopic screening. The first scenario is an endoscopy at time of colonoscopy for colorectal cancer screening with mapping biopsies and continued surveillance every 3 years if IM is diagnosed. And then the second scenario is endoscopy at time of colonoscopy with mapping biopsies every 2 years, irrespective of pathology, compared to no screening, and along the Korea cascade. And they found that gastric cancer screening with endoscopy and mapping biopsies might be cost effective for Asians, Hispanics, non-Hispanic Blacks, but not for non-Hispanic whites in the United States. And that's another simulation model looking at incidentally detected GIM and whether surveillance endoscopy is cost effective. And they found that universal surveillance every 3 years was cost effective. And they also looked at high-risk subgroups with a shorter surveillance interval, and that also was found to be cost effective. So key takeaways from this talk is that gastric cancer screening is not routinely recommended in the US, but it may need to follow a personalized approach, so more like under precision medicine, with a special focus on high-risk groups. Patients with GIM need to be tested for H. pylori and undergo risk stratification to determine if surveillance is warranted. Simulation models suggest that gastric cancer screening at 50 at the time of colonoscopy may be cost-effective in non-Hispanic whites, and surveillance of GIM every 5 years in patients with incidentally diagnosed metaplasia or sooner or at shorter intervals in high-risk patients may also be cost-effective. And of course, more US-based studies are needed to guide gastric cancer screening and prevention in the United States. Thank you.
Perfect. Thank you. Thank you, Dr. Raphael, for fantastic presentation. So what I'm hearing from you and Dr. Thoda is we need to move away from this 2 and 3 minute endoscopic exam to perhaps a 6 and 7 minute endoscopic exam. Perhaps we might do a 22 station exam like the Asians one day. But the question that comes to my mind is, given the fact that intestinal metaplasia is a precancerous condition, and we have that's the only condition that we know of that we can detect and leads towards early detection of cancer, can we do a Sydney protocol biopsy on all patients who are at high risk on their index exam?
I think that's a great question. And I guess, what do you mean by patients who are at high risk? Are they at high risk because they have known precancerous lesions or because they have risk factors, potentially immigrants from high incidence regions? And yes, if we are concerned that those patients are at increased risk, I think the Sydney protocol is very helpful. And ideally, being comfortable detecting gastrointestinal metaplasia and atrophy and dysplasia endoscopically is even more valuable for these patients.
Great, great. What are your thoughts on AI, the use of AI? How can we incorporate that into early detection?
I'm sure it would be very helpful, especially that those lesions can be very subtle at times. So incorporating AI to detect dysplastic lesions or intestinal metaplasia would definitely be of great help, just like with colon polyps.
Great, great, perfect. Yeah, there was somebody asking about AI at the same time. There's a question here that asks how do smoking, obesity, alcohol, and diet contribute to gastrointestinal cancer risk, and which are the most strongly linked colorectal versus upper GI cancer?
Mm-hmm. This is a great question, and I always counsel my high-risk gastric patients about those risk factors. Those are risk factors that are also known to be associated with stomach cancer: alcohol, high-salt diet, canned foods, red meats, processed foods, smoking. I don't think there has been studies looking at their effect on GIM or pre-neoplastic lesion progression, but we know that they are associated not only with colon, but also with stomach cancer. So I do counsel my patients to minimize or potentially sometimes even eliminate certain risk factors from their lifestyle and diet.
Sure. Perfect. Well, that's amazing. Thank you so much. That was truly enlightening. If there are no other questions, I want to wait for about 10 seconds to go on to the next presentation. There's another comment says, what evidence supports lifestyle interventions in reducing the incidence of stomach cancer? Do we have enough evidence, Dr. Raphael, about it?
As I said, those are risk factors associated with stomach cancer in general, but reducing the incidence or progression, no studies that I know of that have looked at reducing or slowing down the progression from preneoplastic to lesions to cancer per se, at least that I know of.
So is it wise to say that we should counsel all our patients, at least at risk, to stop all processed foods, perhaps? Yeah.
I mean, we all know those are carcinogens. So
there you go. Okay, perfect. Thank you, Dr. Raphael. It was wonderful listening to you. Let's move on to our next presenter now, who's Dr. Ari Garber. Dr. Garber is the Assistant Program Director of our fellowship program at Cleveland Clinic in gastroenterology. He has a huge interest in teaching some of our fellows and with colonoscopy and immense interest in early detection of colon cancer. Dr. Garber, you're up.
Thank you so much for the opportunity and welcome everybody. It's a pleasure and honor to be able to speak to you today, and thank you to our moderators as well. And today I'm going to speak about colon cancer screening updates and particularly focusing on new modalities and new technology. It's apropos that I'm speaking about this today as in the United States, March is Colorectal Cancer Awareness Month, and so truly apropos. The problem, stated simply, is that colorectal cancer, or CRC, ranks third in terms of cancer incidence in the United States. And unfortunately and concomitantly, colorectal cancer ranks number 2 in terms of cancer mortality. Now, this is a busy slide, but I want to focus your attention on the top 2 graphs. In terms of overall incidence of colorectal cancer, we've seen a significant decrease in both localized, regional, and relative flatlining in terms of distant colorectal cancer in all ages. But this sort of hides a subtle trend in an increase in early onset colorectal cancer in individuals less than age 50. And for that reason, we're actually seeing currently now a risk of colorectal cancer in individuals less than age 50 of 12%, and it's projected to be 15% in 2030. For this reason, that is the major reason why our United States guidelines changed the recommendation to start screening at age 45 from 50. Our United States Preventative Service Task Force recommends both invasive and non-invasive approaches for screening and surveillance. But unfortunately, adherence rates for colonoscopy are subpar, around 60%. As many of you are aware, and as the National Comprehensive Cancer Network, adequately identifies, colonoscopy, or the standard of care for screening, is multimodal. We have colonoscopy that's offered every 10 years, a flexible sigmoidoscopy that can be offered every 5 to 10 years, CT colonography, which is every 5 years. We don't necessarily utilize, but it is in some of the guidelines, high sensitivity guaiac-based testing annually, FIT testing annually, and then of course, multi-target stool DNA testing, which is also referred to as Cologuard, and I'm going to discuss others as well. The standard of care is sort of expanded, and there's been an introduction of new technology in terms of multi-target stool RNA testing, which is also offered every 3 years, and of course, cell-free DNA testing, which is blood-based. Those are the 2 new updates in colorectal cancer screening that are offered at this time. So the first one is ColoSense, which is a stool-based test, multi-target stool RNA test, which is similar to Cologuard, but Cologuard uses multi-target DNA. And then, of course, as I mentioned previously, our blood test, which is the Shield cell-free DNA test to detect colorectal cancer as well. ColoSense was evaluated in an article in the Journal of the American Medical Association looking at multi-target stool RNA tests for colorectal cancer screening. In that research trial, they looked at 8,920 individuals included in the primary analysis and found that the sensitivity, and that's the second line in this graphic, the sensitivity for ColoSense was 94.4%, which is quite excellent and comparable to Cologuard, the one above it, which is the multi-target DNA test, and was equivalent with respect to advanced adenoma sensitivity at approximately 46%. And above, both of those two tests are compared to fecal immunochemistry testing below. Now, the Shield test in 2024 looked at blood-based testing for colorectal cancer and looked at cell-free DNA blood-based testing in this realm. The Shield test, or the Shield trial, looked at 7,861 individuals and comparatively looked at sensitivity profiles for colorectal cancer and advanced precancerous lesions. Unfortunately, as this table depicts, the sensitivity for any stage of colorectal cancer as detected by the Shield test was 83.1%, missing approximately 17% of individuals with colorectal cancer. And it was not, it was quite difficult at detecting advanced precancerous lesions at 13.2%. So when you think of patients that you want to screen for precancerous and high-risk lesions in addition to colorectal cancer, the Shield test did not meet the mark. Similarly, there is another test that is not FDA approved as yet, but is approaching the market, which is Freenome. And it is similarly a blood-based test that also performs suboptimally and comparatively to our Shield testing. When we look at sensitivity and specificity of all screening modalities, colonoscopy remains king, but again, it is quite invasive. So as you can see from this graphic, colon cancer sensitivity for colonoscopy is approaching 95%, whereas flexible sigmoidoscopy and various other modalities, with the exception of CT colonography, which is not offered in some areas, is lower. And then in terms of true incidence of advanced adenomas and sensitivity of detecting advanced adenomas, various screening modalities do better than others, with colonoscopy, CT colonography being higher than Cologuard, and of course the blood-based testing. Relatively new data, as in gastroenterology in 2026, is looking at exosome-based liquid biopsies, which is just blood-based exosome technology, looking at RNA within capsulated proteins, looking for cancer-related cells in the blood. And this has identified a relatively reasonable sensitivity for high-grade dysplasia and, of course, for colorectal cancer, with some caveats. Now, no mention of screening for colon cancer should be without cost. And while Medicare, Medicaid in the United States does cover, and most insurance plans do cover, the majority of screening modalities, that's not the same everywhere throughout the world. The cost estimates are quite significant, and of course, the more invasive testing is more expensive, with colonoscopy ranging anywhere from $1,250 to in excess of $4,800, whereas stool-based testing can be as cheap as $24. So in summary, in our key takeaways from this discussion on key updates in screening for colon cancer screening is effective at identifying our early onset colon cancer. Colorectal cancer screening modalities remain underutilized, particularly colonoscopy with 60% uptake. And blood-based testing, while FDA approved, can be considered one other modality, more effective testing is declined or refused by patients. It's a pleasure to talk with you guys today, and I hope you learned from this talk.
Of course, thank you. Thank you, Dr. Garbo. That was fantastic. Now, where do you see the research in colon cancer prevention going? Is it blood? Is it stool? What holds the key here? Because clearly 60% is in today's day and age with colonoscopies kind of unacceptable. So people are not accepting of this. Perhaps there is another modality. How do you see this developing?
Great question. And you know, the honest answer is the best test is the one that the patient will complete. And many factors go into that. And with respect to completion, blood-based testing is probably going to be stool-based testing followed by colonoscopy or invasive-based testing. And that goes along with cost as well, although blood-based testing is more expensive than stool-based at this time. So where do I see things going? I see things going towards blood-based testing, but not at the current level of which we have sensitivities for testing with our new FDA-approved Shield testing, if that makes sense.
Yeah, it does. There's a question here about Lynch and FAP. I know there are guidelines for screening for these patients. Do you want to touch a little bit upon that? Somebody's putting in that question.
Very, very much so. So what I touched on is screening in average age individuals. What I recommended was not related at all to high-risk individuals. Family history of colorectal cancer, family history of advanced adenomas, genetic precancerous syndromes. And in those individuals, colonoscopy remains the mainstay.
Good. There's a question here that says, in case of mal-prepared or unprepared colonoscopy, when do you consider repeating the colonoscopy? That's
Great
a load.
question. Yes, it's unfortunate that this occurs more frequently than we like, but the recommendation is to repeat within 1 year, and typically next available at the patient's convenience. But the guidelines recommend within 1 year of a poor prep.
Got it. Fantastic. All right. That is good. I'll wait for another 30 seconds, Ari, before I
Sure.
switch on to the next presenter. Yeah, there's another question that asks, how do red flag symptoms for lower GI cancer differ from features that can be managed with watchful waiting plus safety netting?
Yeah, great question. So when we talk about screening, we're talking about asymptomatic individuals. If you have a patient with hematochezia, abdominal pain, weight loss, other sort of red flag signs, these recommendations that I promulgated a few moments ago do not apply. Colonoscopy would be the approach. That watchful waiting is not a plan with a screening modality plan.
Yeah.
Good question.
Important, Ari, would be, even though if the patient has had a screening colonoscopy in the past, we know of missed lesions, and if there is a red flag upon follow-up, say 1 year, 2 years down the line, it's important to consider rescoping the patient, even though the patient might have had a colonoscopy in the past.
100%. Yes. So the sad fact is that and it's hard to study what you miss, but in studies, it's estimated that between 10 and 25% of lesions are missed. And we're not necessarily talking about, mass lesions and things like that, but it does humble you to recognize that between 10 and 25% of lesions are missed. And sometimes you notice that individually when you do procedures on individuals who are actively bleeding from a prior recent colonoscopy, a post-polypectomy bleed, and it lights up the bleeding actually lights up the colon like a chromoendoscopy, and you see additional polyps. So it is a true statement to say that we do miss lesions, and the goal is at least a 6-minute withdrawal, or those some guidelines are now not guidelines, but new recommendations are to extend that out to 9 minutes to reduce the risk of missed lesions on withdrawal of colonoscopy.
Perfect, perfect. That's great. That's fantastic. Thank you, Ari, for the fantastic talk. Last question: quantitative versus qualitative. I knew there would be a lot of questions for you, Ari. There's some more, but quantitative versus qualitative fit test.
So, qualitative. So, fecal immunochemistry testing is truly measuring human blood in stool. It's not like the old hemocults that it could be missed by dietary ingredients and whatnot. So qualitative is reasonable. You don't have to have a true value. It's either black and white, yes or no.
Right. Perfect. Perfect. Thank you so much for answering them, Ari.
My pleasure.
Perfect. Thanks. Let's move on to our next presenter. He needs no introduction. Dr. Tyler Stevens is the director of the Pancreas Clinic at Cleveland Clinic. He's going to enlighten us about early detection of perhaps the most dreaded cancer amongst all of GI cancer, which is pancreatic cancer.
Thank you so much, Syed. And I think to most people, I may still need an introduction, but I appreciate the flattery. And thank you for inviting me. Do I need to hurry through this presentation, Syed?
About 12 minutes.
Okay, because I noticed the time we were kind of advanced, so I'll do my best to be efficient here.
Got it.
So my portion is on the prevention and screening of pancreatic cancer. And of course, we all know this cancer to have a very dismal prognosis, and that's mostly because when patients come into our offices with symptoms, they are typically at an advanced or even kind of an incurable stage. And so most patients present at stages 3 and above, and unfortunately, most of these patients die with the cancer. However, in the few patients, and you can see it is a relative few, that present at an early stage, these patients have a better shot and actually have a fighting chance at survival. The estimated survival for stage 1 cancer ranges from 44 to 80% in studies. Hence, the idea of screening patients who are asymptomatic sounds appealing. We can't do this in the population because it's just not cost effective or feasible. The cancer is rare, 13 per 100,000 annually. And even if we were to run a sensitive screening test in average risk individuals, we would have a very low positive predictive value, meaning most of the positive results we would get would be false positives. And this would lead to a lot of unnecessary imaging, invasive procedures, patient anxiety, and most importantly, cost. And for all these reasons, we can't really do screening in the general population. But the idea that is promoted by many experts in the past few decades has been to take patients who are at a high risk genetically and subject them to screenings. And hopefully this could be something that is feasible and beneficial. So most guidelines that we have on familial pancreatic cancer screening, which by the way is not done throughout the entire world, but in a growing number of countries that have the ability to offer this, we're starting to see this really take off in the last 20 years. And most of the guidelines that we have available advocate screening when the lifetime risk of pancreatic cancer exceeds 5 or 10%. And that's why taking a family history as well as genetic testing is very important in terms of delineating the population at risk. So the high-risk individuals are divided into those who have mutations that increase the pancreatic cancer risk, as well as those that don't have mutations when they undergo multi-gene testing, but who have a strong family history. Regarding this latter category, the cancer kindred analyses that were done using SEER data show that the risk of pancreatic cancer increases to 6 or 9-fold in those with 2 first-degree relatives, and up to 15 to 20-fold in those with 3 or more first-degree relatives. And of course, there are other so-called risk modifiers, such as if there's a family member who developed cancer at a young age, less than age 50, or just the overall number of relatives, including second and even third degree relatives. So if a family has more than three or more second degree relatives, for example, this may also be an additive risk factor. For patients who are considered eligible for screening, we typically start at age 50 or 10 years younger than the earliest PDAC case in the family. This is with the exception of certain so-called high penetrance syndromes. For example, we start at age 30 in Poitts-Jaeger syndrome and age 40 in patients with familial atypical melanoma or FAM, as well as hereditary pancreatitis. We use MRI and endoscopic ultrasound for screening because neither of these has radiation. Of course, CAT scans would have that cumulative radiation risk over time. Neither of these modalities has radiation, and both can detect very small and subtle lesions. That's why they're favored for screening. Each test has different attributes. The MRI is best for detecting small cystic lesions, as well as delineating the ductal anatomy and seeing stricturing in the pancreatic duct. It also sees the entire abdominal compartment and may occasionally detect meaningful extrapancreatic lesions. EUS is best for detecting small solid lesions and also allows for biopsy. Now, we typically alternate these tests, so an MRI would be done year 1, an endoscopic ultrasound year 2, and so forth throughout the patient's entire life or until such time that screening no longer makes sense for the patient. We can also modify the schedule, of course, based on if the patient has surgical anatomy that precludes an EUS, or if they have significant anesthesia risk, or conversely, if they need a luminal examination or a concomitant colonoscopy, we sometimes may reverse the order of tests as needed. Now, the primary things that we're looking for on screening, what are we looking for? What are we looking to detect? Well, the holy grail target for screening is a stage 1 PDAC that's resectable and is node negative. Okay, this is really the goal for our screening so that we can intervene effectively. Other actionable precursors might be an IPMN with high-risk features such as a mural nodule or an adjacent ductal stricture, for example. Or if we have a cytological aspirate from a cyst that's showing high-grade dysplasia. These are additional actionable lesions that might result in a surgical resection. At this point, the evidence for screening is relatively weak. And so there is really an ongoing debate over the value of pancreatic cancer screening. There are no randomized trials or proven mortality benefit for pancreatic cancer screening as there is with colon cancer and certain other cancers. So we are basically left with prospective cohort data. And these cohort studies that come from expert centers, many of whom have promoted and invented, so to speak, familial pancreatic cancer screening. Most of these have no control arms. They're also subject to various biases, including lead time bias. And as you recall, lead time bias occurs when earlier detection may increase the measured survival time from diagnosis, even though it really isn't changing the time of death. So it can be deceptively, improved survival, even though there's lead time bias going on. Nonetheless, when we look at these published high-risk cohorts, we do find reasonable yields for detecting meaningful high-risk lesions. These rates are taken from a meta-analysis of 19 cohorts comprising 1,600 plus patients. And in this meta-analysis, the rate for discovering high-risk lesions, either high-grade dysplasia lesions or PDACs, 0.74 per 100 patient years, i.e. 1 lesion per 135 individuals screened over time. Likewise, there's a reasonable surgical resection rate of 2 to 5% of screened individuals during the period of their ongoing screening and surveillance. However, not all of those patients that had resection actually ended up having cancer. In fact, some of them had low-grade dysplasia and a cyst, for example. Speaking of that, there is a high rate, as one would expect, of branch ducti PMNs, probably in line with the average risk population. And in fact, in these cases, we typically manage them conservatively. Proponents of screening highlight that pre-symptomatic screening shifts the stage at diagnosis. Most of the patients are diagnosed in stage 1 when they're found during screening. Likewise, there are high resection rates. And also the reported 5-year survival is on the high side, 60 to 70% in screening detected cancers, which compares quite favorably with normal pancreatic cancer detection. Here is one of our own screening successes at Cleveland Clinic. And I'm certainly not meaning to brag about this success because really over the past 20 years, we've had only a few similar cases that frankly could be counted on one hand. Okay, this is a 55-year-old asymptomatic male who has 2 first-degree relatives with PDAC and an ATM mutation. His index EUS revealed a 2.5 centimeter mass in the body of the pancreas. And after neoadjuvant therapy, he underwent a distal pancreatectomy with splenectomy, and 9 years later is doing quite well and cancer-free. In over 2,500 high-risk individuals that have been published thus far in cohort studies, according to a search that I just did, and over 12,000 patient years of follow-up, only 100 to 150 screen-detected cancers have been reported worldwide. So it's kind of a little bit underwhelming in terms of the number of successes, that, at least those that are published. There may be many more that are not published. And if you estimate that screening costs around $2,000 to $3,000 per patient per year, we need to spend about $300,000 to $500,000 to detect one cancer, not to mention the downstream costs. This is just rough calculations. So one can reasonably debate the cost effectiveness of this approach. The published guidelines that we have are evolving, and they're including even more potential patients for screening. The original CAPS study guidelines, the CAPS consortium guideline, was the seminal one published in 2013 and revised in 2020. The AGA guidelines mirrored the CAPS guidelines, although they were a bit more conservative in their inclusion criteria and less enthusiastic for screening. In terms of highlighting the weak evidence that we have. But in both these guidelines, patients with most common mutations like BRCA2 require a family history of pancreatic cancer and at least one first-degree relative to be considered for screening. What has changed majorly is that the ASGE and the NCCN guidelines have come out in the past few years, and they have shifted in a meaningful way. Specifically, they advocate screening BRCA and ATM and even, I think, PALB2 carriers, even if they have no family history of pancreatic cancer. And they advocate that these mutations carry around a 5 to 10-fold risk, 5 to 10% risk of pancreatic cancer, and that's why they advocate screening these patients. Well, this has really opened up the floodgates for our pancreatic clinic. We're seeing so many patients now because this multi-gene testing is being done all over the place in all different kinds of cancers, breast cancer, ovarian cancer, prostate cancer. Even patients are having direct-to-consumer testing done, and they're found to have these mutations. And so there is a growing identification of a whole new population that may benefit from pancreatic cancer screening. And so I believe many of these patients are still at a relatively low risk of developing pancreatic cancer, and the numbers are so high that I fear that it's becoming very resource intensive and difficult to scale. And so this is going to pose some important challenges to our healthcare system. So I think the question of how we meet these challenges, I think we need to take a step back, if at all possible, and try to consider how we may improve our risk stratification of patients, how we may streamline and cull the pool down to a smaller, more manageable group of patients who would truly most benefit. And I think this is going to require the development of predictive models and blood-based or molecular biomarkers that can help narrow down and target our screening to those who are most likely to benefit. And fortunately, there are some big, large consortiums that are well-funded and are trying to get at the answers here and really help make this a cost-effective and feasible approach for patients. I think there are many patients who are concerned and worried about their pancreatic cancer risk, and we do our best to serve those patients and to give them the best possible care. But I think we still need further investigation and research in this area. Thank you so much for your attention.
Thank you. Thank you, Tyler, for that fantastic presentation. I think it's enlightening and humbling as well at the same time. And perhaps one day we'll have a test, one blood test or one stool test, which can tell us, hey, this patient is going to get cancer 5 years from now. For the sake of time, there's a question in the chat box about diabetes. Tyler, would you want to spend like a minute to tell us about diabetes and the risk of pancreatic cancer?
Yes, well, of course, diabetes is a known risk for pancreatic cancer. And practically speaking, any adult patient, particularly a thin patient, but even in a patient with metabolic syndrome who is developing diabetes, the possibility of that as an early marker for pancreatic cancer should cross your mind. And depending on their symptoms, their weight loss, their genetics, their family history, cross-sectional imaging to investigate should be considered.
Perfect. Thank you. Thank you so much. I want to move on to Dr. Shilpa Juna. She's the director of our liver transplant clinic, and she's going to talk to us about liver cancer. Shilpa, you're up next. Shilpa? Dr. Juna?
Dr. Juna, you are muted and you need to reshare your screen.
Great. Sorry about that. I was having problems with my mute button. Are you all able to see my slides?
Yes, we are.
Okay, thank you so much. Thank you for inviting me, Michelle and Syed. I'm excited to talk about this topic. It's very close to my heart. We're primarily going to focus on hepatocellular carcinoma today. This is the third leading cause of cancer death worldwide. And unfortunately, without treatment, 5-year survival rate still remains around 18%. Males are affected twice as often as females, and it's actually estimated that 2-to-1 ratio, it's probably even greater than 2-to-1. Peak age that's affected is usually patients between 60 to 70 years. In the United States, MAFLD and MASH is rising. Viral hepatitis is declining because of kind of the advent and accessibility to hepatitis C medications. But worldwide, viral hepatitis as a cause of HCC is still pretty prevalent. Over here on this map, you can just kind of see incidence of HCC worldwide. You can see that it is worldwide still predominant in areas that are impacted by viral hepatitis. And you can see that it's also rising in the United States, likely due to the MASH epidemic that we're experiencing. So when we talk about prevention of HCC, I think as a hepatologist, one of the biggest things that we always ask, the first question that comes to mind when we're diagnosing HCC is with regards to, does this patient have underlying liver disease? Do they have a history of cirrhosis? Identification of liver disease is crucial. 39 to 50% of patients with HCC are found to have undiagnosed cirrhosis. So oftentimes I have patients that come to our clinic that had no idea that they had cirrhosis and were kind of just living silently with the disease. Late diagnosis of HCC has been shown to be associated with worsening survival outcomes, and 1 to 4% of cirrhotics are known to develop HCC annually. So how can we prevent this? In the United States, the CDC has recommended that everyone should be screened for hepatitis B and C at least once in their lifetime. For women, it's actually advised now that you should be screened for hepatitis C with every pregnancy. And MASH and alcohol-associated HCC is rising in Western countries with incidence, and has, is kind of higher in incidence in Western countries than it is in Asia, where viral hepatitis is still pretty prevalent. But this has really become more of a common cause for HCC, a rising cause, so to speak. We do know as hepatologists, this has been studied as well, and many of us are familiar with how weight loss can help with reversing hepatic steatosis and fibrosis. And that applies for alcohol-related steatosis, but especially for metabolic-associated steatohepatitis. About 5% of weight loss is associated with reversal of steatohepatitis on blood work. But if you achieve 10% weight loss, you can start to see reversal of steatohepatitis and fibrosis pathologically. Ultimately, why this matters is steatosis leads to steatohepatitis, which can directly bypass fibrosis, and in 5% of cases of MASH-related HCC, contribute to HCC, or the fibrosis can progress to cirrhosis and lead to HCC. So about 5% of cases of MASH-associated HCC occur without presence of cirrhosis. And we're expecting that that number is probably going to increase in the future. Antiviral treatment for hepatitis B has been shown to decrease all-cause and liver-related mortality. It does decrease cancer risk as well, because hepatitis B has been shown to cause a direct oncogenic effect on the liver and cause hepatocellular carcinoma even in the absence of cirrhosis. This is just two other diagrams that kind of show the progression of chronic liver disease to HCC. This particular diagram was actually taken from an educational site at University of Washington that was talking about hepatitis C, but this diagram is actually very relevant to most cases of cirrhosis. Once someone is diagnosed with compensated cirrhosis, their risk of evolving into end-stage liver disease or decompensated cirrhosis requiring transplant is about 2 to 5% per year. But you'll see here that HCC risk is also high, 1 to 4% per year. Over here, this is a diagram of MASH-associated cirrhosis and liver cancer. It's estimated that about 5 to 10% of patients with MASH-associated cirrhosis will go on to develop HCC within 10 years. So going back to screening for liver disease, that's where we can really probably catch a lot of early HCC. So MASH and MAFLD, the rise of MASH and MAFLD has led to FibroScans being used to screen for hepatic steatosis. This is something that's done daily in our liver clinics to exclude steatohepatitis and early steatosis. MR elastography for patients with higher BMI, where you may be concerned or not have the right probe for your FibroScan to screen for MASH and MAFLD, is also important. I always screen everyone for alcohol-related liver disease, although there might be a predominant cause of liver disease that could then be contributing to the patient's HCC. You should always think about coexisting disease processes. So using something like Audit-C to screen for alcohol use is important. And ultimately, the million-dollar question of, does the patient have cirrhosis or not? We get a lot of imaging reports that comment on nodularity, cirrhotic appearing liver. One of the things that I think can really tell you if this patient is a compensated cirrhotic or decompensated cirrhotic is evaluating their platelet count, looking for signs of clinically significant portal hypertension. For example, if someone has a platelet count of 150,000 or less, that is associated with clinically significant portal hypertension and advanced liver disease. And looking at cross-sectional imaging, a lot of our patients have CT scans that may have been done for some reason or the other. So looking for presence of varices, recanalization of the umbilical vein, these are all indicative of CSPH as well. So what are our screening methods? In the United States, still recommended by ASLD and ACG, ultrasound abdomen plus AFP every 6 months is standard of care in all cirrhotics. Now, if you have a patient with hepatitis B and they're non-cirrhotic, we still advise that you should do HCC screening in Asian males and females that are 40 or 50 years of age or greater, respectively. African patients that are 20 years or older, and those with any family history of HCC, especially if they were less than age 50. But really, HCC diagnosed at any age still would be appropriate for HBV-associated HCC screening. So the current cutoff that we use for alpha-fetoprotein has been optimized at around 20, and that's been associated with a sensitivity of 60% and a specificity of 84%. When you add ultrasound to this, you see that the sensitivity increases from 60% to 96%. And then when you look at it, though, for early HCC detection, which is defined as lesions that are less than 2 centimeters in size, the sensitivity is only about 53%. And the reason why this matters is early detection helps with outcomes, post-HCC diagnosis helps with survival. So how can we improve this sensitivity is a big question right now in the liver world. So there's one short case that I have here. This is with regards to a 72-year-old male. He comes in with fatty liver disease. His BMI is 38. We order a fiber scan, which is suggestive of cirrhosis of the liver. There's elevated stiffness. The patient's platelet count is 120,000. You end up getting an ultrasound and note the BMI is 38. His AFP is 15. And the questions that I think of in this situation are, was this an adequate test for this patient with this BMI? What follow-up testing would you like to order for this patient? And what factors in the patient's history impact testing? So, the BMI being over 30 actually can significantly impact the ultrasound results for HCC screening. So this leads us to kind of the world of new biomarkers for HCC. So there's two that have kind of become more well-known and have started to be embraced by many hepatology and transplant centers in the US. We have started employing these in use at Cleveland Clinic as well, starting last year. One of them is DCP, which is an abnormal form of prothrombin. A value of 7.5 or greater has actually been associated with a 4.8 greater risk of HCC development in cirrhotic patients. It has a high positive predictive value and sensitivity, especially in patients that have HCC secondary to hepatitis B or C infections when you compare it to AFP L3 and AFP. As with any test, there is lower specificity as sensitivity goes up. And so trying to find the perfect value, which would be considered to be most sensitive to capture as many patients, has been difficult. I will say that this is kind of the value that's been accepted in literature recently, but this is under some scrutiny and probably may change in the future as well, but it is an important marker nonetheless. We often now recommend that patients get AFP L3, which is a variant of AFP, and basically we get a percentage, and then also use DCP for HCC screening. So a value of 10% or greater is considered to be a positive cutoff for AFP L3, and this is associated with the 7 times greater risk of HCC. So another score that you might hear about that is actually in a phase 4 validation study called TRACER in the US incorporates age, gender, AFP L3, and DCP levels. And the idea here is, again, trying to aim for early detection of HCC. So catching lesions even that are less than 2 centimeters very early on, or potentially even precancerous lesions like nodular regenerative nodules that are progressing to HCC. So GALID has been shown so far to have superior performance to ultrasound alone They have not done studies that have compared it to ultrasound and AFP. However, this validation study is in progress right now, and hopefully the data will be coming out in the next couple of years. And the inclusion criteria for this study are patients with cirrhosis or with chronic hepatitis B as well. I also want to mention that for post-transplant recurrence, both of these markers have been associated with increased risk of developing HCC post-transplant. So having an AFPL3 of 15 or greater and DCP of 7.5 or greater have been associated with increased risk of recurrence after transplant as well. There's also methylated DNA markers. This is kind of known as liquid biopsy. These approach sensitivity and specificity of 90% and are really good, again, for early detection of tumors. This has not been FDA approved yet. These are in kind of investigational trials, but this potentially could be something that we start to use more in the future and that might be embraced more in the future. So ultrasound versus MRI, we talked a little bit about in our last case. If the BMI is greater than 30, we usually advocate for an MRI for screening over an ultrasound. The MRI can certainly increase sensitivity. It is best at evaluating small lesions. Ultrasound sensitivity for small lesions is anywhere from 47 to about 70%, but if you use MRI, that's closer to 90 to 95%. The specificity, however, doesn't change too much between the two. Of course, again, like we've been talking about throughout this talk, changing survival outcomes and changing treatment as a bridge to liver transplant are very important. So if we can detect HCC early and change someone's outcome, that's of most importance. And then ultrasound sensitivity, like we've talked about, can be impacted by obesity, but it can also be impacted by the presence of steatosis, whether that's from alcohol or MASH. So just one last fun slide that I have here is about coffee, because I get this question probably about once a month about, should people be drinking coffee to decrease their risk of developing liver cancer or to, help with regression of fibrosis? There is one meta-analysis, probably the biggest meta-analysis that was published in BMJ a few years ago. It was about 2 million people. What they found is that caffeinated coffee up to 3 drinks per day is actually associated with preventing liver cancer. And it included patients with pre-existing liver disease, whether that was viral hepatitis or cirrhosis. It is low grade. So, we know that it could potentially be helpful, but I also caution people that this is really black coffee. So any additives, creamer, milk can add to the calories and technically could increase your risk of developing fatty liver, which would kind of counteract all of this. So black coffee is preferred. So key takeaways: screening for cirrhosis and chronic liver disease are key to preventing HCC. GALAD is in validation phase. It may eventually replace AFP and ultrasound for HCC screening and has already been embraced by many centers. Methylated DNA tests are also being evaluated. When in doubt about ultrasound quality or accuracy of the imaging in a patient with MASH, go ahead and order an MRI, and definitely counsel all patients on the importance of HCC screening. Don't let them miss any interval screening. Thank you so much.
Perfect. Very nice. Thank you so much, Shilpa. This was amazing. Very enlightening, of course. For the lack of time, I'm not going to ask any questions. There are a few questions in the chat box. If you don't mind, please go ahead and answer them for the benefit of the audience. I know we've extended a little bit beyond our times, but thank you so much. I can see that everybody who logged in initially is there. I can vouch for it. I've calculated and seen those names. So everybody is here. That just speaks for the quality of the presentations that we had today. I would like to thank all the presenters today, Dr. Michelle Kim, for giving us an opportunity to do this as well. And that brings us to the close of this presentation.